Our host for today asked me who was going to introduce me, but I told her this is breakfast 120 or something in that range. We've been doing that many of them for 10 years, so I don't think I need an introduction. For those of you who don't know me, my name is Anton Hart, and I'm the publisher of Longwoods Publishing. So there you go, Deb. That's done, right? But our host today is Rotman, and it's delighted to be here. This is a great facility, a wonderful facility. We've been here before. And Deb Fisher, on behalf of Rotman, just wants to welcome us here. So, Deb Fisher.
Hi, I'm Debbie Fisher. I guess there's two Debs here today. I'm the new executive in residence at the Rotman Business School in the Healthcare Strategy Center. And I'm really pleased to have all of you here today. I think it's going to be a great session, and with the amount of people here, I think we're all interested in hearing from Deb Matthews, our minister, and also interacting with her in discussions.
Great. Ladies and gentlemen, the Minister of Health and Long-Term Care, Deb Matthews. Deb. So Deb's going to do things a little bit different today, but I'm going to ask her to explain what she's going to do. So it's your show, Deb.
Well, thank you, Anton. Good morning, everyone. Happy to be here with you this morning. I kind of think of coming to breakfast with the chiefs as an opportunity to check in with the sector. So I thought what I would do today, rather than giving you a nice speech, including the things you already know, I would turn the tables a bit. So what I thought I would do is give you a little bit of an overview of how things look from my side of the table, and check in with you about how it's looking from your side of the table. I want to talk about where we are on the implementation of the action plan, and I want to talk about a next step that I'm thinking we need to take, but I want your input on it. So let's get started. So it's almost 2 years ago that I launched the action plan. And just as a bit of a refresher, 3 pillars to the action plan. The first one is focus on wellness, keeping people out of the healthcare system. The second pillar was about a stronger role for primary care, so people could get faster access to primary care, that they would go to their primary care provider first before they go to the ER. The third pillar, I always say we cheated on the third pillar because there are 3 pillars to the third pillar. Right care, right time, right place. They told me I couldn't have 5 pillars. So the third pillar has 3 pillars: right care, right time, right place. And the right care is focusing on evidence and really driving our healthcare system to make investments, spend money where there's evidence that outcomes improve as a result of those investments, and not spend money on things that don't improve outcomes for patients. That's harder than it seems. I think everybody agrees with the principle. The implementation meets with a little bit of resistance. So that's the right care. Right time, almost always sooner is better in healthcare, so getting people access to the care they need in a timely way. Right place is where we're really putting a big emphasis and driving a lot of change and seeing measurable results. The right place is all about getting people the care they need at home or as close to home as possible. We've seen some tremendous progress on that right place component. Our ALC rates, I don't think I have to define that for this crowd. Our ALC rates have dropped by 25% as a direct result of increased investments in the home care and the community care sector. The home first philosophy, where people, what used to happen is where people would, elderly people particularly, would be admitted to hospital. Maybe they had a fall or a stroke or something. They'd be admitted to hospital. They'd be told then that they couldn't go back home. They'd be told before they had recovered fully that they couldn't go back home. And what we've found is that if we make significant investments in that home care, people can go home, people can get better to the point where they can actually stay home. I recently had a personal experience with home first philosophy, and there are thousands of these stories. A gentleman, a friend who was in his 80s, had a stroke. They told him, you have to go into long-term care. He said, over my dead body, literally. And they said, okay, let's take another look at this. They got him the right support at home, intensive support for a few weeks. Then he booted out CCAC and lived very happily at home for another year before he did then have another stroke and pass away. That's the action plan in action. That gentleman got the right care, the right time, at the right place, better quality care for him, less expensive for the system. So one of the, so there's a lot happening, I don't have to tell you, in the healthcare system as we implement the action plan. Health system funding reform is, and I acknowledge this, very, very difficult for the healthcare sector, particularly the hospital sector, as we move from global budgets to paying hospitals based on their, the communities they serve, the demographic characteristics of the communities they serve, and the procedures that they do in those hospitals, the services they provide. So we are in the middle of a difficult, I acknowledge, a difficult transition from deeply mysterious block funding to transparent funding where hospitals are funded on the basis of the services they provide. That's tough, and I want to take this opportunity to really applaud those of you in the hospital sector for embracing health system funding reform. I know how difficult it is. I know how challenging it is. I think you all know that it needs to be done, and I just want to say thank you for not causing a big ruckus over this, because there are times when a big ruckus would have been caused. So thank you for that. I want to just touch on health links. There's a lot to talk about, but I'm going to make this short so I could hear back from you. I am enormously optimistic and excited about community health links. And how many of you are involved in some way in a community health link? Several of you. So I'm going to just describe the idea behind community health links. So you know we've been working hard getting parts of our system functioning better. But when we realize that 1% of Ontarians consume about 1/3 of our healthcare dollars, 5% of us consume 2/3 of our healthcare dollars, it's important to get the parts of our system working well, but it's even more important to get the transitions of care working well. Because those 5% that consume 2/3 of our dollars are people with complex needs, and they will be accessing far more than just one part of our healthcare system. So how do we actually get all of us working together with wrapping care around one person and their family? Because that's really what health links are all about. I think what the old way was, and very often, you know, we see this in our own family. We'd see somebody who was in the healthcare system. We all knew that they weren't getting optimal care. They were getting lots of care, but it wasn't coordinated. It wasn't working for them. And people would say, they should do something about that. They should fix that. It's somebody else's fault. I'm doing my part. Somebody else isn't facilitating this. There's not enough money being spent on that. This isn't working. Now with community health links, we're all in this together. So when something isn't working for a patient, then it's our job to fix it. It's our job. The members of the health link are empowered to fix the problems that are preventing people from getting the best quality care at the best value for those precious dollars. So I announced health links about a year ago. Instantly, 19 communities put their hands up and said, me, I want in, let me be an early adopter. We're now at 37 community health links. We're looking forward to, in the not too distant future, where we will have health links established right across the province. So every complex patient in the province will have access to a health link, and those health links will be empowered to deliver the highest quality care with the patient at the center of that plan of care. That's what's really important. There's a lot that's new about health links, but for me, the thing I like the most is that we're engaging patients and we're engaging their family members, and the care, their plan of care, reflects the needs and the wishes of those patients. Helen Angus is here. Helen is, stand up, Helen, our Associate Deputy, yes. So Helen is, I call her our silo buster. So she's been brought in. She has a very clear job description from my perspective. I don't know what Saad has to say about it, but my perspective, Helen's the silo buster. That means if the system isn't working for patients, then she has to change the system. She has to make it work for patients. So she's been out and about across the province talking to people, and I have to tell you, as I said a minute ago, I'm enormously optimistic. When I see frontline providers excited about something in healthcare, excited about a government initiative, then that warms my heart. So I'm very excited about Health Links. The part that I want to sort of get a bit of ask you to be a sounding board for me is the whole issue of patient engagement, the patient experience. How do we actually make the system work for the people who the system is for and who actually pay all of us? The provider, we are paid by taxpayers, we are paid by patients, and I'm not sure that patients feel like they're the boss. I'm not sure that we are making the system work for people. I think that there are some good examples in parts of our healthcare system where we're actually engaging patients in their own personal plan of care at the organization level, like the hospital, at the system level. We've got a few patient advisory tables, but it's still, I would say, peripheral at best, and it is certainly not institutionalized. So I've been thinking a lot about this, and I'll tell you why this keeps coming back to haunt me. I, as you can imagine, get lots of letters. Occasionally, I get letters from people who say, thank you, the system worked for me. More often, I get letters from people who were not happy with the care they received. So I find myself reading the letters, because I do think these offer real insight into how our system is working. I read the letters, and then so somebody's not happy with the care they received in a hospital, for example. I then look at the letter that the ministry people have drafted for me to sign, and I read the letter, and the letter says, here's what happened to my mom when she went to the hospital. It didn't work out. I don't think that was the care she deserved. And I write them a letter saying, sorry to hear about that. Figure it out with the hospital. And they've already exhausted that, right? They've already said they tried that and it didn't work. And I send them back to somewhere. Now, I know there has to be a finish to that process, but it doesn't feel right to me to send them back to the organization they're not happy with. So how do we deal with that? What do we do about that? Somebody here is jumping up here to talk about that. But this is the issue that I'm wrestling with now. I'm not here to tell you this is what we're going to do, the new strategy, a new initiative. I'm telling you it bothers me. I'm not happy with where we are right now. I know there's good work happening in parts of the province, but I need your advice. And there are some people here, and you think I would have planted these people, which is only partly true, who maybe could lend a little insight into that. Now, Angela is right here. Angela, can you stand up? So Angela is, Moran, is on the, oh, we have a microphone for you. Come up, Angela. Did you know, they warned you this was going to happen?
A few minutes ago.
Yeah. So Angela is on the Family and Patient, what do we call it?
Patient and Family Experience Advisory Council.
Talk right into
Oh,
your mic.
sorry.
Say that
Patient
again.
and Family Experience Advisory Council.
At Kingston General.
And I sit on the Southeast Regional Cancer Center Patient and Family Advisory Council as well.
So Angela,
Yes.
talk to us about what difference you think you're making.
Okay. Well, first of all, I'd like to say that I was really excited just now listening to you talking about health links because it's really all, for me, about the patient and family and the system working around them. And I became involved after going through an experience with a very close family friend who went through breast cancer and finding the system very overwhelming, wondering why we were the ones having to navigate around everyone else, and balls being dropped and things not happening that should have happened. And so that's what prompted me to get involved with the advisory council. And so the concept of health links and having the system revolve around the patient is really exciting. I can see how patient advisors could participate in that because if you're talking about revolving the system around the patient, patients should be asked. Patients and families should be asked, what do they need? It's all about not assuming that you know what patients and families need. It's about involving them. I see patient and family advisory as a collaboration and a partnership. It's not an adversarial role. I don't even see it particularly as an advocate role. I see it more as this was my experience, this is the experience of the patient advisors, this is what would help us. This was what would make it better. And so we're really looking to help make it better and help make the system better. I've participated at KGH on a number of working groups and committees, and some of them involved patient navigation. And it was really interesting recently in working on hiring panels with patient navigation, where the patient navigators that were currently in the position said how much they had learned about the other allied health workers and the other people in the system being in that role, and that they had a whole new appreciation for the scope of care that other people could offer and started to utilize that in a much better way for the patients to expedite their experience in the hospital and getting them home again. So there's a lot, I think, that patient advisors can bring to the table and give another perspective that can really help to make it an easier process.
Thank you. That's great. Don't go far. We might have questions for you. Yes. You know, our long-term care homes now all have resident councils, and many have family councils as well. I met with a woman who's president of her residence council, and I asked her, I said, so what are you doing? What are the issues that you're focused on? And she told me two things. She said, the first one was there was a really unpleasant smell in the home, and it was bothering patients. So they worked with the Environmental Services Department at the long-term care home, and they have fixed the problem. That's a pretty big improvement in quality of life for people who live there. The second thing that they're working on now had, I'm not sure anybody who worked at the home would have thought about this, but she said, our laundry system means we have really scratchy, like sandpaper towels. And when our clothes come back from the laundry, they feel really stiff and uncomfortable. So now they're working with the home to change their system. There's an ozone system or something that apparently produces nice, soft, fluffy towels. But that's the kind of thing that patients would raise as issues that that management might not see. So, that's just another little example. Kathy Fuchs, I saw you. Kathy, where are you? There you are. Kathy, I'm sure many of you know, is with the Change Foundation, and they've been doing some really interesting work. So I'm going to ask you, Kathy, did they warn you? Yeah, just go with the flow here. None of you are free from this, I want you to know. So I'm going to ask you if you can talk just a little bit about the work you're doing on this.
Thank you, Minister. Good morning, everyone. We're involved in a large project in Coburg at the moment called PATH, which is bringing together patients and family members and providers in equal proportions, and a number of people in the room are part of the team, right here in the front, who are patients. And we are basically redesigning the process of care in Coburg. So we start with patient stories, we listen to the kinds of things that you've just talked about, and then we ask the providers to put on their thinking caps with the patients and the families and redesign the care. So we have things like, when you first go into a healthcare provider's office, what do you want to say to the provider as a patient, as a family member? There's a whole process of talking about yourself and your family and your job, not your disease. And then we have a whole process of reinventing the way in which people go through the system. So I think very similar to what the health links are doing in terms of patient-centered care, trying to think about a better way of organizing care around the family and their needs. We're going to have early results by the end of the year, and we're going to save some money. So that's probably good news for you.
Indeed it is. Not that I want to save it, I just want to put it somewhere else. Because there's no shortage of things I'd like to fund. So I guess I want to throw it out to you, but Kathy actually touched on something. In case you're thinking this is some sort of flavor of the week or some sort of wouldn't it be nice if, or something even political, it actually does save us money. There is good evidence now, very good evidence, that demonstrates that when people are engaged, they actually need less care from us. Their length of stay is shorter, their participation in their wellness is better. There are a lot of system benefits to actually listening to the people we care for. So I am going to stop talking now, and I'm going to throw out a question to you. And the first question is, I want to get any insight you might have in how our action plan is being implemented from your perspective. How are we doing? Yes.
I'm going to give you a mic even though you don't need one. Shalom.
I think that things are very exciting. I think that things are changing. They're
Why
changing.
don't you stand up and face the audience?
I'm Shalom Globerman. I'm president of Patients Canada. And we work with Kathy Fuchs, and we've worked with people at Kingston to talk about the role of patient and family advisors and the role of patients in general bringing their voice and their experiences. I think that the most important thing is to hear people's experiences and their actual experiences and see where the system is missing things. In the PATH project, we discovered that the kinds of things that are missing are almost negligible. It's things like helping with vacuuming that would make a huge difference in people's lives. And introducing those capacities and the capacity to support people in living in the community with very small things will allow them to do that much better. And we find that that's beginning to happen. There's a will that's beginning to appear where this is happening. So we're very excited. We think that at the Patients Canada, we gather these stories like you do. And we hear many, many of them. And we've come to the conclusion that by and large our system is distorted. We've put a huge amount of money into acute care, and we don't have enough support in the community to keep people at home. And shifting that money isn't going to be easy. You're quite right, Minister. But that shifting has to happen. And it can happen slowly, and it can happen gently, and it can happen without harming very many people, but in fact helping huge amounts of people by providing the small supports that people need and the constant supports that people need to live actively in the community. We've developed a series of indicators now that are based on these changes happening. And these indicators are very simple. There are a series of policies and practices that are taken on in hospitals and in other organizations that show that they are actually looking at and considering the patients directly. And I'll give you an example.
And then I'm going to...
Okay, I'm talking too long. Okay,
Okay.
no, good back to you.
No,
I'm
give
sorry.
us the
I could go
example.
on for 2 hours.
I know you could. I was doing that. So you give the example.
I'll give the example. The example is a simple example. The example is that when you call your primary care doctor, you sometimes, how many of you have to wait for a very long time to get an answer? Nobody. Oh, a few. Oh, all of you are answered almost immediately. How many of you can make your appointments online? 1, 2, 3. How many of you can communicate with your primary care doctor online? A few more. It's changing, actually. It used to be that there were even fewer. How many of you can get your test results online? A few more. But you see how little that is, when in fact all of this technology is really simple and can be brought into mind and can be done securely. I think that that kind of change in primary care will make your lives much easier.
Great. Thank you.
So, Minister, we have mics all over the room, so you can pick
Okay,
anybody
there are
anywhere.
mics all over the room. So why don't you, yes.
If you stand up, we'll find you.
Hi there. Thank you very much, Minister, for coming and speaking with us today. You asked about a few things that we're noticing in primary health care and in patient care in general. So I speak from the experience of coming as a clinician, but also leading the primary health care information practice at CIHI. And there's a few things that I've noticed over the past few years. Number one is really around, I think the policy levers and the influence that the ministry has can't go unnoticed. So I think there's been a huge emphasis on teams in Ontario, as evidenced by the fact that so many Ontarians now are actually cared for by teams, whether it's CHCs or family health teams. I think that that's had a huge impact on the patient experience. The good news is patients may not know that they have a team, they just know that they can get care, which I think is critically important from the patient perspectives that I'm hearing and from the care providers there. So I would speak to the fact that there's a huge team. It's not just doctors or nurses or nurse practitioners. There's lots of people like social workers and pharmacists and other allied healthcare providers who I think are doing really good work in this space. And I think the ministry has done a good job of helping to lead that from policy and from the implementation of the Healthcare for All Act. I think in terms of goal setting, 3 years ago probably, I wouldn't have heard nearly as many primary care providers talk about setting goals with patients. And now all I hear from almost all of them, and it's in Ontario, but it's also across the country, is setting goals. How are we going to track whether we've set goals for patients? And so even having some policy levers around that, how can we incent that? How can we really make that happen? Because then it requires you to have a conversation, somebody in that care team to have a conversation, say what's important to you. And I guess the third thing is really understanding, so all of this is driving a need for data and information. And I can't obviously be from CIHI and not talk about the need for data and information, which all of you tell us that you need. And I think the important thing about that is that as care providers, you start looking at, well, how are we doing? How should we be doing? What are our patient expectations? And are we meeting them? And so it's great to have Shalom talk about the patient experience, because now, and I'm very proud to say that within the past 2 weeks, I've just sat at a table with Ministry, Health Quality Ontario people, and a number of people who are stakeholders in this community around developing a patient experience survey for Ontario primary care patients. And I think that that's a huge area of focus now, and I'm so happy to see that happening. So thank you.
Thank you. Thank you.
Hi, it's Serena Wheel, and I work in the area of patient experience at the Ontario Hospital Association, and I coordinate the standardized patient surveying for Ontario. And I know that we now have an e-health patient advisory committee. Any thought to a top-end ministry-level patient advisory committee?
You're asking me if there's any thought that we have?
Yeah.
So, I have to say this is something I'm actively noodling. That's a technical word. I think what we have now isn't good enough. I haven't absolutely landed on what we need to do to make it better than it is now. So, that's where I am right now. As I said earlier, I just know because I get letters from people, I talk to people, it just doesn't, it's not sitting right that we've come so far in so many ways, whether it's our wait times or access to primary care or, a number of major system level improvements, that now it's almost like now we can turn our attention to what might have in the past been considered just something to get around to later. I think the time has arrived for us to figure out a framework on how we actually, and surveys are important, but surveys are not engagement, right? Surveys give us a sense of how we're doing, but they don't actually engage people. So, and you know that in the Excellent Care for All Act, we actually put that in the Act so that people do have to measure, but that's different than engagement.
Absolutely.
So you won't pick up the richness of the patient experience from surveys. So we've got a patient advocate at Orange. We've got a drug system advisory board that's made up of patients. We've got some things in across the provincial system, but that's I'll be honest with you, it's something that's under development.
Great. We're here to help.
Thank you.
We're going to have a lot of questions, and we're going to be here till 10 o'clock. I think the ones at that mic are first, and then I'm going to come back to you.
Hello, it's Lisa Priest. I'm a former journalist.
there you are, Lisa.
Yes. How are you? I wanted to say a few things. I think HealthLinks has been terrific in terms of being able to help patients, because I stood here a few months ago saying to Kathy Fuchs, I can't see how patients can co-design something so complex, and actually we co-designed a coordinated care plan that we're going to be piloting soon. So the lesson I learned from that is to start before you're ready, and to be very patient-heavy, and then you can get it done and not make it so insurmountable. But back to your point about the being a former journalist, I know the things you deal with in terms of if anyone has a complaint in the healthcare system, you're in the legislature, and you're the person who has to answer for it. And one of the things I found in hospitals, and it's not a criticism, it's more a system thing, it's if I'm a patient and I have a complaint, that complaint may relate to quality, or it may be communication, or maybe a number of things, but there's no standard way. It's done differently in every single hospital. And if I'm a patient in any hospital, it should pretty much be the same, that I know where to go, who to go to, and there's an appeals process if I don't like the first answer that I get. And that maybe that person is, once I deal with patient relations, maybe there's some kind of board where I go before and there's a quality person and they look at it through a quality lens instead of always looking through it through a complaint lens. But that's just one of the things I've noticed in terms of patients having power. It's this feeling that you're looking all through the system. Most of the time you're pretty happy, but for the ones who aren't, the complaints really do matter, because they're almost always, I think in some ways, very significant, one way, whether it's communication, or another way in quality.
Thanks, Lisa. Let me just make a couple of comments. So, every hospital has a process. Some operate in a much more engaged way, where they invite the patient in. They say, if you weren't happy, then we're not happy. Let's understand what happened, and let's work together to find a solution so it doesn't happen to somebody else. Other hospitals, I get the sense, are like, do not, you are wrong. You have no, you don't know what you're talking about. You got great care here. Go away. So there's a difference in tone from hospital to hospital, for sure. And I think you're absolutely right that no matter what hospital somebody goes to, they should have confidence that if they have a concern, it should be heard by someone who actually wants to listen to them and improve the system through their experience. The other comment I'm going to make is that so much of care now, and so much of where we've got opportunity to do better, is in the transitions of care. So somebody could, the issue could be not confined to one part of our system, it's a cross system. Many of you have heard me talk about the relay race that our patients run, and it's the passing of the baton that's so important. And so we have to figure out how we're going to design something that incorporates that transition of care piece as well.
Absolutely, just to pick up on that, because I remember when they looked at some picker data on patient satisfaction, something like 92% of patients were satisfied. But I think also when in the PATH project they found that when they asked about their coordination of care, like 49% of people were satisfied with it.
Yeah.
So that's an easy way, well, not easy, but it's a very specific mechanism to sort of coordinate their care, and they'll obviously be more satisfied.
Yeah, and the other bonus, one hospital CEO told me that once they changed their attitude on complaints, they actually saw lawsuits plummet because people didn't feel they had to resort to the courts, that their issue, they just don't want it to happen to somebody else. So, I mean, most people really do bring nothing but goodwill to the system. The other just little thing I want to say is, there's one thing is responding to complaints, and I think I just lost, oh no. We heard from Angela that it's actually about preventing those complaints. So how do you engage people in a way that we actually don't see those complaints? So thank you.
All right, Minister, the advice that I would like to add to
Okay,
this
cool.
discussion is the legislation
For those of you who don't know Camille Orridge,
is the excellent care for all part of the Act. So as we begin to do all the patient engagement, all of this work, is then there's a second, and that's a great place to start. There's a second place in that, which is when I look at who the people are in GTA who are coming in for care, they're not often represented in those facilities. So there's a difference. We tend to end up with a class-based participation. We need to recognize that and then figure out other ways of engaging the other people who don't have the time, the skill, the language to participate the way the other teams have participated. So I think it's good to start, but I'm just afraid that we may miss that other portion. And the question is, how many people in hospital come in for care, don't speak English or French, and yet go through complex procedures without being able to fully understand? I know in Toronto, several hospitals and communities now have access to a telephone. But for me, that's a basic quality issue to talk about engagement. So there's some key things like that that I think should be standard across healthcare, such as the ability to communicate. And I'm not sure if that's standard in practice. So how do we then talk about quality of care and engagement when we can't even communicate? So those two things, I think, must be built into the framework. And it's not just a team is great, an advisor is great, but there are communities that we need to engage differently to get their voice into the system. And they may not be the people that will come and sit at committees. So we've got to build that in as part of the patient experience agenda as well.
thank you, Camille.
I'm going to go to the central mic. State your name, please.
Good morning. Hi, Minister Matthews. I'm Dr. Nicole Nitty from Access Alliance Multicultural Community Health Center. And it was a wonderful talk. I'm very happy to be here today. And I wanted to say a few things. First of all, that as a family doctor in the community health center sector for the last 5 to 10 years, I've certainly seen some incredible changes in the attitude and understanding of what primary care is and how it can impact communities and the health of people. One thing I just wanted to comment on is that during this change, I mean, clearly it's not an easy fix. It's not a one-step process. But one thing that I've found is that there's two aspects. There's the philosophical change that's required, and then there's the practicality of it. And the culture of healthcare organizations can sometimes make those things two separate things. I mean, for example, with the professional interpretation that's available in a greater part of the GTA, there's still a lot of providers that aren't actually using it. And it's about balancing these little things like that were mentioned before, like the smell of the facility, which to workers and whatnot, we wouldn't even think about, or we think they were stupid, or we would think that, oh, you know, like they're getting everything else. They should be grateful for the care they're getting. You know, how many times have we heard that before? And balancing that with what we are actually able to offer. And I think that is something that we misunderstand people-centered care as being we are obligated to give people everything they want, and that there is a limit, and about that conversation about what it is that we can provide for the actual patient. And I think that, it's really important to look at organizations and how the structures of healthcare organizations are dealing with that and how they can sort of bring those two things together. The philosophy, getting providers and administrators to really embrace what you're talking about, and then developing the systems that can make it practical and logistically easy for providers to do on the ground.
Thank you. My experience is that most people don't ask for too much. Their expectations aren't really very high. I mean, they want excellent care. They want to be treated with respect. They want to be heard. They don't want to sit in a waiting room for hours on end. Their expectations are not, filet mignon for lunch. Their expectations are very, very reasonable. And we just have to provide care a little bit differently to respond to that. Thank you.
We'll try to get everything in, so hold on. Reza, you're next.
Hi, I'm Reza Deber, and I'm going to throw the academic piece in because, as it would happen, we're actually putting a grant application in to look at patient engagement in partnership with the ministry. And one of the things that became clear when we looked at it is the term patient engagement is used to mean many, many things, and there's a lot of confusion about it. Most of what we've been talking about here is the meso level of system navigation and how do you make sure that the system is set up to make it easier for people to navigate and work better. But a lot of the other question is what happens at the individual choice level of what care an individual patient will get. And on that, and we can talk off ice if you want about some of the confusions that arise there, and actually Shalom's helping us in the study, and Cancer Care Ontario and a few others. But the right care that you focused is really important because in the US, there's been this tendency to think patient engagement means the patient decides what the right care is, which most people don't want to do and are not equipped to do, as opposed to deciding what the right care is for them and what trade-offs matter and how they want to manage things. And I think it's really important to take what you said at the beginning, one size doesn't fit all. I'd love to have somebody do my vacuuming. I don't need to have the public pay for it. In some other cases, it may make a lot of sense. So the question of what should public pay for, what should private pay for, where do you draw the lines, how do you do it, what makes sense for individual patients, how do you do it? But it's really important not to have the patient engagement rubric overwhelming the idea that we're also looking at right care and appropriateness as opposed to how do you navigate a system.
That's very, very good input. Thank you.
Now we'll go back to the back.
Hi.
Over here. We're going to be here a long time, Minister.
Hi, Teresa Boyle, Toronto Star. Minister, what do you think of the idea of the provincial ombudsman having oversight of hospitals so patients could go there if they have complaints? A lot of groups are calling for that, and other provinces do it.
That's one option. It's always hard when there's a reporter in the room because you have to be careful what you say. I think healthcare is very complex. The issues that we deal with around patient care and the change we want to drive to improve the patient experience is a lot more complicated, a lot more you have to deal with it every single day in every single setting. It's whether ultimately there's ombudsman oversight or not, I mean, that's a question that I'm sure we'll continue to debate. But I do not for 1 minute think having ombudsman oversight will drive the kind of results that I expect of this sector.
We'll come back to the front.
Hi, Minister Matthews. I'm Candace Chartier with the Ontario Long-Term Care Association, and I just wanted to let you know the impact on the Health Action Plan and it's changing the population of our long-term care sector, and that is with the investment in Behaviour Supports Ontario. I don't know if any of you realize this, but out of the 77,000 residents that we look after every day, 46% of those residents exhibit aggressive behavior. And I just want to share one little story of the successes. With the investment of Behavior Supports Ontario, we had a younger man, late 50s, early 60s, exhibiting really aggressive behavior. The resource person for PSO spent some quality time doing the assessment and the analysis and looking at that man and really focusing on the new approach to resident-centered care. He was a chronic smoker, and he had no control. He had no control coming into the long-term care home because he couldn't decide when he was going to go out and have a smoke. And that resource person spent time with him, built a care plan around him, let him control his schedule, his care routine. That man stopped smoking within weeks, started becoming engaged in the home, started participating in the programming, and started to really become the man that he used to be in long-term care. So that's just one little story of how BSO has impacted our population, and kudos for that health action plan because it's making a huge impact.
Well, thanks, Candace, and yeah. You know, there are some wonderful little gems that we should all know more about, and Behavioral Supports Ontario is one of those gems where we're training people, whether they're caregivers, unpaid caregivers, or people who work in long-term care, insight and training on how to look after people with dementia and behavioral challenges. It's not intuitive to know how to deal with someone with dementia. Yeah.
I don't know.
Just wait for the microphone here.
Oh. Our convention that we have every April is the largest seniors convention in Canada. And what we did last year was we brought the Pioneer Network in from the States. We built the whole convention around the Pioneer Network and culture change in long-term care. And since we've had that convention, we now have a culture change initiative through long-term care on resident-centered care. So I think it's really creating a shift.
Minister, maybe I can offer that people who have gems like this, if they send them to Longwoods, we'll publish them the next day, if they're accepted to our editors, right? But I gotta add that. We're going to go way to the back.
Good morning, Minister Matthews. My name is Craig Thompson. I sit on the steering committee for patient experience at CCO. I also am the board chair for an organization called Progress Place, which
Can you speak more into the microphone? Thank you.
I sit on the steering committee for patient experience at CCO. I also am the chair of the board of Progress Place, which is an organization that deals with people with persistent mental illness, which is highly patient-centered. I also work in a hospital. So I see the idea of patient experience from many, many different areas. And I want to speak to the idea of the cultural change or shift that has to occur in hospitals, and the idea around the ownership of the patient experience, that while we have a patchwork of people who see patient experience as being part of their mandate within a hospital system, there's no one individual who actually owns it soup to nuts, from the point where a person wakes up in the morning to the point where they're actually in our hospitals to the point when they go back home again. Can you speak to the idea that we need to have, maybe at the C-suite, someone who is actually tagged with the responsibility for patient experience?
Sorry, C-suite?
At the very senior level of the
At the
hospital.
seniors, sorry. Well, I mean, you're absolutely right. That patient experience is everybody's responsibility, and it's, you know, if you look at what patients say about their care, they'll often talk about how lovely the cleaning staff was to them. So it's everybody makes a contribution to that patient experience. But should somebody have that overarching responsibility? Absolutely. I mean, we aren't going to drive change unless we actually measure what it is we're trying to do, have a strategy to implement, and make it happen. So, yes, do I think somebody should? Yes. Should it be the CEO? Yes. Does the CEO need to delegate it, some responsibility? Perhaps. But yeah, it is for me a very big and important responsibility that's right up there with all the other responsibilities in terms of quality of care in an organization.
Okay, Leslie, come on up.
Could I just ask one, would you see patient experience actually being part of someone's title? Kingston, I think, has that in the title of the person's job.
Well, interesting let's listen to Leslie Thompson at Kingston General.
Thank you very much. In relation to this, from an accountability perspective, I do think it belongs and needs to be owned. Through my experience at the CEO level, what we do is, but probably more significant, is we made the decision about 4.5 years ago that every decision in our organization where there's a material impact on the experience of patients, a patient will be at the table. We didn't have a clue how we were going to get there. So we've worked with people like Angela, Eleanor, and others to figure out, co-design our way of how we were going to do it, and that was vital. You can't say, the CEO, now we're going to have patient experience, and I want 10 of those to be there. You've got to be really careful not to make sure that you've got a token thing. In fact, one of the worries I have actually with all the excitement, and it's happening nationally and internationally, of involving and engaging patients, is we've got to worry about either the professional patient advocate, single issue advocate, but that tends to be more in the minority, and then also the kind of the exhaustion. We're talking to we now have 55 patient experience advisors at KGH, and they're everywhere, and we worry a little bit about some of the kind of exhausting the goodwill. We do try and get folks from very diverse backgrounds, but one of the interesting things in BC, they actually, Kathy Fuchs had brought them out at one of the sessions on patient experience, and the government actually invested a little bit in an organization called Voices, I think, or Patient Voices. And what they're doing is they're kind of training and supporting patients from all different backgrounds and things to be able to participate. Because it does take, we spend a lot of time and effort on orientation, both of our patients and our staff. And it's new, because once you go down this route, it changes everything. And so that might be also building the capacity to support the really meaningful engagement, because the worst thing that can happen is just kind of the token. Yep. And patients will call you on it in a heartbeat, because they know when they're a token, and it's not okay. So that may also be something to consider, to try and make the patients included notion more systematic across our system.
That's very good advice.
Minister, last question to your left here.
I just want to make a quick comment. I had the honor of attending a meeting of the Patient and Family Experience Advisory Council at Kingston General, and I'm going to be honest, I was a tiny bit of a skeptic, because I thought it was token. I thought it was tokenism, and it isn't. And the people who were in that room, who talked to me about what they do, who talked to me about about their expectations, about the change they could drive, was really changed my mind and really got me to think about how this can work. But at KGH, they don't hire people without the Patient and Family Experience Advisory Council giving the stamp of approval. They're there in hiring decisions. That's the depth of the engagement there. Pretty cool. Yes.
Hi, everyone. My name is Catherine Chow from Baycrest. I'm curious more about the Health Human Resource Plan, especially for geriatrics. As you know, all of our numbers and our demographics point to a burgeoning baby boomer class, if you will. So I'm curious as to what we are doing to attract more physicians to practice in the area of geriatrics. One of the things that has been very successful for Baycrest has been our alternative funding plan, so that we can attract talent and retain that talent. So things like that are really useful. So, but more a longer term strategy as to what we're doing in geriatrics.
So you've put your finger on a real challenge for our system, that whole health human resources, and it's not just limited to geriatricians. We talked to PSWs about, as we invest more in the home and community sector, we're going to need more personal support workers. So this is very top of mind for us. when it comes to AFP payment for physicians in hospitals, we're actually leading the country on that front now, and I think there's lots of opportunity to do more of that. So if that's helpful, I'm glad to hear that. And we want to do more of that, because we need to broaden the scope of practice. We need to have all our health professionals working at their full scope of practice. This is very much an active area right now. Because interestingly, when the OMA students came to Queen's Park this year, every year they come with their top issue that they want politicians to know about. The issue they came to us with the last 2 years, not just this year but the year before, was we want to make sure we have a job at the end of this. You're training us, you're investing a lot, we're investing a lot, and too many of us are graduating and not finding jobs in certain specialties, right? So this is a very live issue.
Minister, I have two announcements which I think you'll like. Number one is that Josh Tepper will be here next month, November 27th, to talk about his work in his new organization, Health Quality Ontario. And secondly, the Ways and Means Conference to make Health Links work. We know it's going to happen next May, and Dr. Sasha Bhatia is the first individual to come and help us and put that together. Fantastic. So we can look forward to that next May.
Wonderful.
Minister, this worked really well. Thanks for the idea. So we may just do it again.
Terrific.
So your appreciation to our Minister of Health and Long-Term Care.